Good afternoon. I'd like to go ahead and get started today. Today is our joint hearing of the Senate and Assembly Committees on Health, on state prescription drug prices, the pricing standards, and the initiative. So I want to open this up as an opportunity for some of my colleagues to speak first, and then I have a short opening statement as well. We do have some, this is a little different for us. This is the first time that I participated in a hearing like this. Well, it's the first time I've done a lot of things because I'm fairly new in the legislature, but this is the first time we've done this as a legislature, and as we're hearing the initiatives going forward. And so we do have a format that we're going to follow. We have some panels that will speak. We have an opportunity for proponents and opponents, and then we will allow some time at the end for public comment. And depending on how many people we're going to finish this hearing up around 4 o'clock. Depending on how many people wish to speak, we'll adjust based on that. And we'll see if the entire room needs to speak, then it may be only an opportunity to say we're in support or in opposition. But if it's a smaller number, we'll adjust accordingly. So, please, we appreciate no applause, no jeering, no whatever. Please be respectful of our process. There is no authorized filming of this procedure today, with the exception of Cal Channel and any credentialed media. And we'd ask any credentialed media who plans to do filming to check in with us, but no one else is authorized to actually film, so we would ask that you respect that as well. So at this point, I'd like to open up this to my colleagues for any opening comments. And the first person I'd like to offer this to is Senator Ed Hernandez, my counterpart in the Senate, the chair of the Senate Health Committee. Dr. Hernandez.
Thank you, Mr. Chair and members. It's a pleasure to be here, and I appreciate everyone joining us today for this hearing on the California Drug Pricing Relief Act. You know, I've been talking about controlling healthcare costs for quite a long time. You know, we've obviously had hearings on controlling drug costs, transparency, numerous ones, and this year I spent a fair amount of time working with stakeholders on the issue of drug pricing. As we all know, the impact of costly drugs on taxpayer resources is massive, with millions of Californians covered by Medi-Cal and other programs, and it's something that we definitely need to have a conversation and to deal with. Given that and the impact of rising premiums, employers, it's common sense that we, as policymakers, prioritize this issue in our work. What I've learned through talking with stakeholders that has led me to introduce my bill, which is SB 1010, which will bring transparency to prescription drug spending. When we made price information publicly available in other sectors of the healthcare market, prices have been normalized, and I would hope that we can continue to have that conversation. But the policy in SB 1010 is just one option to address the rising drug costs, and there are many others, including the policy that we're going to be learning about today. Clearly, the rising cost of prescription drug is a major problem that needs to be addressed. And obviously it's the role of the legislature to hear all the propositions through the appropriate policy committees. That's the role of what we're going to be doing here today. I'm going to be doing a lot of listening, you know, just asking some questions. But at the end of the day, it's whatever the will of the people decide, and as it moves forward. But we're here to look at the policy. And with that, Mr. Chair and members, I thank you for the time to make some opening comments.
Great, thank you. Other members? Mr. Chu.
Thank you, Mr. Chair, and I want to thank both of the chairmen of our Assembly and Senate Health Committees for holding this very important hearing on this very important topic, which is the reality that millions of Americans and Californians are seeing about skyrocketing drug prices. In recent months, we have seen bipartisan congressional committees investigating drug prices and finding incredible things. We've seen a pharma CEO who was arrested for fraud. We have heard from presidential candidates from, on the Republican side, Donald Trump and Marco Rubio, to on the Democratic side, Hillary Clinton and Bernie Sanders, who have said that we need to tackle this topic. And we've seen surveys of Californians and Americans, 3/4 of which of the public who are saying that our drug prices are way too high. In fact, on the Republican side, drug prices are the #1 health priority over the repeal of Obamacare. Last year, I had a bill in this committee to establish some drug price transparency for the highest priced drugs, to really get at the question of how much does it cost for the highest priced drugs for research and development versus marketing and other expenses, compared to billions of dollars of profits that we've seen. And we all know who the faces are of this issue. It is our seniors, it is our terminally ill, it is Californians who have cancer, who have hepatitis C, who have AIDS, it is children, it is millions who have chronic pain, and unfortunately, in many instances, are paying $1,000 per pill that we know costs a tiny fraction of that to manufacture. And despite last year, a very significant coalition of labor and business leaders, consumer advocates, and health plans, hospitals, and nurses, our bill stalled in the Assembly, but the conversation continues. And let me just say, from my perspective, I, along with our colleagues, we are all looking for solutions. I think every member of the legislature, we all appreciate the importance of this research, of cutting-edge health benefits, and we understand and appreciate the defense of the industry, but we need solutions to skyrocketing drug prices, and we need answers, and that is part of what I'm hoping we're going to hear from today.
Thank you. Other members? Any other members? Okay, and I'd like to make a short statement, and then we'll invite our first panel up. Actually, if they'd like to come up, we'd be be ready to roll. That'd be great. We'd appreciate that. So, well, first of all, thank you all for being here today. As Chair of the Assembly Health Committee, I'd like to welcome everyone to this informational hearing. This is a joint hearing, so you'll see senators and assembly members here, and you'll see people come and go as schedules allow. So please just understand that's part of the nature of our world here. So this is an opportunity for committee members and the public to hear and better understand the initiative that will appear on the November 16th ballot. Prescription drug costs continue to rise significantly every year. Patients are finding that many drugs that have been on the market for years suddenly increasing in cost by 10 to 20% or more per year as they near the expiration of their patents. One drug company announced plans to increase the cost of a single pill used to treat a parasitic disease that can affect those living with AIDS and cancer from its long-standing price of $18 to $750 per pill. A new innovative specialty drug to treat hepatitis C was initially priced at $84,000 for a 12-week course. The average price of prescription drugs, new and old, is higher in the United States than in any other country. These ever-rising prescription drug costs affect all Californians through higher insurance premiums, increased prescription drug cost sharing, and higher taxes to pay for state-funded health programs. There are many examples. Fee-for-service Medi-Cal spent nearly $25 million treating roughly 340 hepatitis C patients with drugs Sovaldi and Harvoni in 2014. And currently the state budget allocates $228 million for high-cost drugs to DHCS, our Department of Healthcare Services, and the Department of Corrections and Rehabilitation. Last year, CalPERS spent $438 million on specialty drugs, an increase of 32% over the previous year. This represented 1/4 of the total drug costs paid by CalPERS for only 1% of the prescriptions filled. People are taking notice. A recent Kaiser Family Foundation national poll reports that over 70% of people, that's Republicans, Democrats, and independents, say that elected officials should be sure that high drug costs for chronic conditions such as HIV, hepatitis, mental illness, and cancer are affordable to all who need them. And over 60% of those polled support government action to lower prescription drug prices. As is clear from this initiative's title, the intent of the initiative is to reduce the price of prescription drugs in California. According to the proponents, it will also increase drug price transparency. Opponents have a different view. Ultimately, it will be up to the voters of California to decide. Now, hopefully, this light can shed some. This hearing can shed some light on this issue. So we have, first of all, a panel here. I'll let them introduce themselves, but this is regarding healthcare costs, and drug pricing. It's an overview. So whoever would like to start, please go ahead.
Good afternoon, everyone. My name is Jeffrey Hotch, and I'd like to start by thanking the State and Senate Assembly Health Committee chairs and the committee members for the opportunity to provide context about the topic of prescription drug pricing. I'm a professor of health economics at the University of California at Davis and the associate director of the Center for Healthcare Policy and Research, CHPR, here in Sacramento. My research focuses on cost-effectiveness analysis which is basically smart shopping in healthcare. Basically, what are you paying and what are you getting? Currently, my team and I are completing a report funded by the California Healthcare Foundation about state options on prescription drug pricing. My colleague, Dominique Ridley, a senior health policy analyst at CHPR, is also co-presenting with me today and is a co-author on the report. The short answer in terms of what we found so far is that major progress has been difficult to achieve. We'll explain why shortly, but to begin with, I'd like to describe how pharmaceuticals fit within healthcare spending. As I'm sure you're aware, prescription drug prices have received a great deal of attention in the media. Local stories describe how our state will be a flashpoint in the policy debate about the cost of high-price prescription drugs, with leaders acknowledging that the cost of prescription drugs is a major challenge. National media frequently have stories like the one you see before you, reporting how experts determined U.S. prices for some new cancer drugs should be cut by as much as 94% to make the cost justify the benefits. A recent New York Times editorial noted that a new cancer drug was priced over $11,000 a month in the United States, 6 times higher than leading oncologists believed was reasonable. Last but not least, an increasing set of prices for some generic drugs have been receiving media attention as well. For those concerned about total costs, there's a formula that can help put potential solutions into perspective. Total costs decrease when the drug price and/or the drug quantity decrease, and rebates can also be used to lower total costs without affecting the price of drugs. When considering the price to charge, a pharmaceutical company might consider the cost to bring the drug to market, it might consider the clinical value, or it might consider what the market will bear. The structure of the pharmaceutical market and relative market power of payers versus manufacturers determines the type and degree of cost control in the market. We will touch on these concepts again briefly at the end of this presentation when we consider how VA prices compare with Medi-Cal prices. As an example of how market structure and bargaining power affect total costs, the New York Times piece I referred to earlier notes that while drugs account for 10% of nationwide health spending, in employer-based health insurance plans, drug benefits account for 19% of spending, which is not a whole lot different from the spending on inpatient hospital care, according to recent analysis by the Kaiser Family Foundation. So what is going on in healthcare spending and how do pharmaceuticals fit? We currently spend about twice as much per capita on healthcare as residents of other advanced nations. In 2011, the U.S. spent 17.7% of GDP on healthcare, whereas none of the other countries ended up spending more than 11.9%. This chart here shows per capita healthcare spending over time. The United States not only spends much more on healthcare, but this spending has grown more rapidly than most other nations. In 2011, the U.S. spent about $8,500 per person, which is more than 2 times the average for other countries. It's important to keep in mind, though, that just because we're spending on something, it doesn't mean that that's necessarily a bad thing. The real issue is, what are we getting for all the additional spending? For some outcomes, we are not getting our money's worth. Looking at average life expectancy at birth, for example, people in Denmark have about the same average life expectancy but spend half as much as we do. Canada and the UK both have greater life expectancy and spend less. In this slide here, we're looking at U.S. healthcare spending per capita, and we can see that it's risen at historically low rates recently, but is expected to pick up. The figure projects growth rates. These growth rates for total health spending are indicated by this line here and suggest continued growth in the neighborhood of 4 to 5% over the next decade. Now you can see these vertical bars. The vertical bars represent prescription drug spending over the same time period. The authors note that prescription drug growth rates declined from 2000 to 2013, in part due to patent expiration, and decreases in generic prices. However, this downward trend is reversing. Spending on prescriptions is estimated to have spiked upwards in 2014 and 2015, with growth rates of 11.4% and 6.8%, respectively. Prescription drug spending jumped up because of new brands, higher prices for existing drugs, and fewer patent expirations. Overall, prescription drug spending is projected to be at or above the growth rate in healthcare spending. However, there are certain types of pharmaceuticals called specialty drugs, which are fueling concerns about high costs. Let's talk about these specialty drugs. Specialty drugs are high-cost prescription medications used to treat complex chronic conditions like hepatitis C or cancer. While there are different definitions about what makes a drug a specialty drug, elevated costs are a distinguishing characteristic. For some chronic conditions, a year of treatment with a specialty drug can exceed $100,000. Research summarized by the Pew Charitable Trust found that, in 2014, less than 1% of all prescriptions were written for specialty drugs, yet they accounted for nearly a third of total drug expenditure. Thinking about the quantity part of the total cost equation, more patients are being treated with specialty drugs. Utilization rose by 5.8% in 2014 because of increased use of existing drugs and the introduction of new pharmaceuticals. In 1990, only 10 specialty drugs were on the market. Currently, approximately 300 such drugs are on the market, and nearly 700 specialty drugs are under development. Because of higher prices and increased use, spending on specialty drugs represents an increasing share of healthcare costs. In 2012, specialty drug spending reached over $80 billion, or just over 3% of national healthcare spending in the United States. The United Health Center for Health Reform and Modernization suggests that specialty drug spending may more than quadruple to $400 billion by 2020, or about 9.1% of national health spending. Their report notes that unit price growth is driving spending increases, but utilization growth also plays a strong role for certain therapies. Now I'll invite my colleague, Dominique Ridley, to conclude our presentation with 3 more slides.
Great, thank you.
So Dr. Hotch has given you an overview about prices, where they've been going, and we want to talk to you a little bit about how the prices are determined and what the laws and regulations are that are out there that alter the marketplace. So we need to understand better about how these prices are determined, and this is important because it provides some parameters for understanding and evaluating proposed solutions. Simply put, the pharmaceutical market has been shaped by rules and regulations that influence the relative market power of the payer and the manufacturer. Some rules benefit the sellers and other rules benefit the purchasers. So on the left side, we can see that the pharmaceutical manufacturers are setting the list price based on a number of the aforementioned inputs that Dr. Hotch had mentioned, including what the market will bear. In addition, there are patents and exclusivity rights that are also affecting the manufacturer pricing strategies. Over here on the left side, on the right side, we see that some payers must cover all drugs, like Medi-Cal, and some can say no when a price is too high, like the VA or the private sector that uses formularies. Some payers must not receive a lower price than Medi-Cal, which is the private payers, and some payers can receive a price lower than what Medi-Cal receives, being the VA. In terms of relative market power, when a pharmaceutical manufacturer has a monopoly, it has more negotiating strength than when there are competitors in the market. The stories that make the newspaper about the high drug costs that are often about payers with constraints negotiating the pharmaceutical companies who have a monopoly, negotiating with the pharmaceutical companies who have a monopoly. So predictably, there's a high price for the product, and either the payer cannot say no or cannot get a price below Medicaid's best price. So next we're going to briefly explore the relationship between the VA and Medi-Cal prices. So by law, Medi-Cal has to cover all drugs, or almost all drugs, that are approved by the FDA. And in addition, there are federal regulations that prohibit the U.S. government from setting the price of pharmaceuticals. So those constraints reduce the number of feasible options for Medi-Cal to get lower pharmaceutical prices. However, there are some protections in place for Medi-Cal. This figure is just a very, very simple representation of where the net prices fall for Medi-Cal and the VA. So essentially, the Medi-Cal basic rebate is guaranteed to all the state Medicaid programs for all drugs. So I'm referring here to this area. However, state Medicaid programs may also receive supplemental rebates for drugs placed on their preferred drug list, which gets us down to this level here. Medi-Cal uses this mechanism to further reduce the costs of some of their drugs. Not all of them, but some that are on the contract drug list that Medi-Cal has. So the important point that we're trying to bring forward here is that prices used in the basic rebate calculations, which is the shared federal-state rebates, are not available publicly. And for those drugs where Medi-Cal has these confidential supplemental rebate agreements, we don't know the prices of what's available. So this is important because we must be cautious with findings from studies like those from the Congressional Budget Office, a report that they published in June 2005 that showed that the Medicaid cost is higher than the VA cost. So the CBO is correct that the VA pays less than Medicaid's best price. However, for particular drugs, year to year, Medi-Cal also receives supplemental rebates for some of the drugs. And so conceptually, it is possible that Medi-Cal could be paying less than the VA. Thus, we have our red arrow here with a question mark because we're not sure exactly what's happening in that mix. So just to conclude with, U.S. pharmaceutical prices are among the highest worldwide, and escalating costs have been a concern for many years. They present challenges for federal, state, and private purchasers. Prescription drugs account for 10% of total healthcare expenditures in the United States, but the rate of pharmaceutical spending, especially in the specialty drug category, is increasing, perhaps unsustainably, in quantity and use. Note that while specialty drugs account for 1% of the prescriptions, they represent nearly 1 out of every $3 spent on prescription drugs now. Experts report that specialty medications priced in excess of $10,000 per course of treatment are increasingly commonplace. And in some diseases like hepatitis C, the drug costs are exceeding $100,000 per patient and are becoming common. And in 2012, all but one new cancer drug was priced at $100,000 per year. Now, in 2014, the latest that we have data for, all but one cancer drug was $150,000 per treatment. So we have other states out there who are considering actions to control pharmacy expenditures, ranging from price transparency requirements to anti-price gouging bans and bans on direct-to-consumer advertising, as well as price parity with the VA. So while many feel that the need to address growing pharmaceutical costs, the exact relationship between the VA and the Medi-Cal drug prices remains elusive. So we look forward to hearing the other presentations today to help shed some light on that.
Great. Thank you very much. I'd like to give my opportunity for my colleagues to ask some questions before you guys move off down there. So, Mr. Chu, and then Ms. Waldron, I'm sorry, please.
Thank you. Just briefly, based on the testimony, in addition to the high drug costs, there's also a lot of other factors that go into when you were looking at the percentage of gross domestic product, the high malpractice costs, over prescribing or even over testing because of the fear of having to deal with malpractice. Did that figure into the gross domestic costs that you were looking at? Or were you only looking at the drug costs in that overall cost?
So I believe your question is about the figures that we were showing that showed healthcare spending as a percentage of the gross domestic product.
Yes.
And the question was, what's involved? What's the definition of the healthcare spending? You're right. It would cover any healthcare spending for whatever reason. So if people were getting something done to them, It didn't matter the reason why. If it was being done to them and someone had to pay for it, it would be counted.
Okay, and just briefly, second question, and I know their estimates are going out to 2020 even, but with some of the new innovative drugs, the remarkable things that are happening, even cures. So these are things we hadn't necessarily seen, in a long time, and it's hard to get around all the data, but there is a high upfront cost, no doubt about it. How does it relate over time, though, when you look at people are actually being cured? So then we won't see maybe transplants, we won't see hospitalizations or other issues down the line. And how do you quantify that, as you go forward?
Thank you again for that question. From my perspective, and again, I'm just speaking on my behalf as a health economist, I think our resources should be used wisely. So if there is something that costs a lot of money and it is able to provide us with a lot of value, from my perspective and from my training, it makes sense to invest in things that provide us a lot of value. On the other hand, I'm also aware that we have fixed budgets. So it's possible we might need to make difficult choices. If we would like to invest, say, more in one area of government, we may need to find resources from another area. And from that perspective, then I think it comes down to what do you perceive as value. And it is possible that something that does cost a lot of money could be quite valuable. It is also possible that there may be purchases that we're currently making that cost a lot of money that may not be putting forward the value that we'd like to see.
Mr. Chair?
Can I add to that, too?
Oh, sure. I'm sorry, please.
Sorry, I just wanted to follow up just to say that the concept about value hasn't really been fully explored in all of the newspaper articles that have been recently published. And I think it's important to understand that there are a lot of resources out there that are starting to explore on a more systematic level and looking at that cost benefit or cost effectiveness of those different kinds of products that are out there. And I think it's an important question that you've asked, because that's basically what you're getting at, right, is what the value is that's associated with that. So organizations like ICER and CTAF in California are performing those kinds of analyses, comparing drugs head to head, to give us answers about that, to help make more informed decisions.
Three quick questions about high U.S. prices, profit margins, and price transparency. So your first bullet point on your concluding thoughts, the U.S. pharmaceutical prices are among the highest in the world, is almost a cliche. We all know this. A few years ago, folks were talking about traveling to Canada for drugs. The most recent hepatitis C drugs, which in the United States are costing close to $100,000, cost a third as much in Great Britain, cost 1% of that amount in Egypt and in India. Could you talk a little bit about what you have found? Why are prices so high in our country compared to others?
So works better if it's on. My perspective is that as you're thinking about pricing your product, you might consider a price that's related to the cost to make the product. You might consider a price that's related to what you perceive will be the value in the market. Or you might consider a price that's as high as the market will bear. And I'm not judging anyone for making any choice. However, if you're in a business where you have a monopoly for a short amount of time, and you have investors who are concerned about recouping their investment, you might face pressures to select one pricing model over another. And you could argue that the United States has higher prices because of the pricing model that the drug companies use in order to figure out what they'll set at. And I think I'd like to leave it at that.
I think we all hear what you're saying. In the United States, I think we all know that as a country, as states, we do far less around drug prices than other countries. And we've certainly heard from tens of thousands of pages of congressional testimony that there are drugs that have been priced because of the lack of regulatory consideration as much as the market will bear. Second question, there is a perspective that perhaps these prices are as high as they are because of billions of dollars of profits that drug companies are seeing. I'm wondering if you've done an analysis looking at different healthcare sectors, comparing profit margins, if there are any conclusions you can draw.